Welcome to our monthly Geri Echo webinar. My name is Sarah Tomkison, and I'm the social worker on our hub team. I'd like to remind everyone that this CME activity is jointly provided by the Queen's Medical Center and the University of Hawaii Jabson Department of Geriatric Medicine. Joining me this afternoon is our interdisciplinary geriatric echo team. We are all willing to teach and share our collective experience and wisdom with you. Please first welcome our advanced practice nurse, Ms. Courtney Nunokawa, and our psychologist, Dr. Lucas Morgan. We also have here today Dr. Reese Ueno, who's our pharmacist, and our physical therapist, Susie Neufeld. And of course, our geriatrician, Rita Bell Fernandez. Just a few housekeeping reminders. For evaluation forms, please remember to complete the required CMEs. And you can find these evaluations by following the link in the chat or at any time on our website and email advertisement. We are currently offering continuing medical education for physicians, DOs, registered nurses, and APRNs, as well as physician assistants. We also offer NASW social work CEUs and certificates of attendance for certified nurses, aides, and students. NASW CEUs will be sent out monthly, but the CME records, those are the certifications or CMEs you need as for physicians and nurses. They get sent out by Queens by mid-January of each year. Your comments are very important to our hub team and useful for the planning committee of future programs. About ECHO, we want to emphasize that this ECHO webinar serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO motto goes, all teach, all learn. And in the spirit of aloha, we encourage each of you to turn on your cameras to help us build a community of learning. And feel free to eat your lunch during this ECHO session, for good nutrition is key to a healthy lifestyle. Our format for ECHO consists of a short lecture from our expert presenters today, with open comments from the expertise of the ECHO Hub team that I introduced to you. And of course, you, the participants, we want to engage you with your comments, questions, and even examples of case for discussion. Additionally, we invite you to share any geriatric cases. And lastly, we ask that you please keep the case discussions HIPAA compliant. And this includes not sharing the patient's name, birth date, address, and so on. Again, we learn best from our patients and our clients. They are our best teachers. It's a pleasure this afternoon to introduce to you our presenters, and they'll be speaking about Kupuna National Resource Center for Native Hawaiian Elders. Our first speaker is Ms. Shelley Munioka. She's a Kanaka Maoli woman born and raised in Heia, Oahu. She is the program coordinator at Kupuna, which is the National Resource Center for Native Hawaiian Elders at the Thompson School of Social Work and Public Health at the University of Hawaii in Manoa. She is drawn to this work because of her passion for Hawaiian culture and the influential role her grandparents played in her own life. Joining her is Ms. Kaylin Kawakami, who is a second-year PhD student studying public health at the University of Hawaii at Manoa. She is a graduate research assistant for Kupuna, and she also conducts research projects to increase health among Kupuna, as well as shares indigenous and ancestral knowledge with future generations. Welcome, Shelley and Kaylin.
Mahalo, Sarah, for that introduction. give Kaylin a second to get our slides up here. Thank you so much for inviting us to share a little bit about our work and for those introductions. I know we have limited time today, so thank you for covering some ground for us already in the introductions, and we'll just dive right in. I'm Shelly Muneoka, the program coordinator at Kupuna. And yeah, Kaylin, maybe you can get into the slides a little bit here. So as mentioned, we're housed at the Thompson School of Social Work and Public Health at UH Manoa. And next slide, please. Oh, we're part of a network of different national resource centers for Native elders. So there's another center like ours in North Dakota that services American Indian elders, and then another one in Alaska for Native Alaskan elders, as well as a center that focuses on elder justice, one that focuses on policy advocacy, one that focuses on long-term services and supports. And so we are all under the Administration on Aging and the Administration on Community Living. And under them, there's an Office of American Indian, Alaska Native, and Native Hawaiian Programming. And so this is the office that also funds what are called Title VI sites. So it's Title VI of the Older Americans Act, and that's a focus on Native elders. And so they support over 300 different direct service sites, including the one in Hawaii, which is Alulike. And today we're going to talk about one of our projects in partnership with them. So first, I like to start a little bit to establish why this center, what is the need? The graph that's on your screen here comes from OHA, and it's a graph that's showing the population impacts of colonization in Hawaii on Kanaka Maoli. So like many other indigenous peoples, the arrival of foreigners meant drastic population declines due to foreign disease. Today, we celebrate the end of Captain Cook and his time here in Hawaii. He unfortunately brought a lot of very damaging diseases to our islands. And the estimate for populations at the time of his arrival in 1778 is a really wide range between 400,000 to 800,000 people in 1778. And so in just about 120 years, by 1890, that number is down to 40,000. So that's 90 to 95% of the population died in a little over 100 years, down to 40,000 Hawaiians. So if you look at this graph, you can see, and this is just for the Hawaiians in Hawaii. So unfortunately, almost half of us now live outside of Hawaii. But as you can see, we're now up to our pre-contact numbers. But we have to remember not only how many of us are there, like the quantity of us, but also the quality of our lives. So the next slide, please. We'll say a little bit more about that. So one of the things that Hakupuna looks at is life expectancy and chronic disease disparities. So we do both quantitative research as well as qualitative. Today we're going to focus on the qualitative, but this is results from previous analysis that we did, and one thing we're working on now is updating these numbers with the new census information. But as you can see on the graph, so this is life expectancy and healthy life expectancy by ethnicity in Hawaii. And so you can see from the 2010 data that Hawaiians were living on average 11.1 years shorter than the longest living group in Hawaii, which is Chinese. And so that's the purple line. The green line, you'll see that Kanaka also tended to become disabled earlier in life, resulting in fewer years of healthy living. And so that's because across the lifespan, we're seeing disproportionately higher rates of chronic diseases like heart disease, cancer, and diabetes. So these are the kinds of things that we're hoping the research we do can help bring awareness to, and through education and resources, slowly chip away at some of these disparities. So we were founded in 2006, and the early work really focused on creating a baseline of data that didn't exist at that time. You could get things about Native Hawaiians across the lifespan and about elders of different ethnicities, but there really wasn't anything that was focusing in on this group. And so that's what our early work focused on. A little bit about our name. So as many of us know, this is Dr. Kikuni Blaisdell, known as Uncle Kikuni to many of us. We were fortunate enough to have him gift us the name of Ha Kupuna. So he was an early member of our advisory committee. Ha is our word for exhaling. It also means to breathe. It also means life itself. Kupuna is our word for grandparent and an ancestor. And it's important to note, like, through our research, we also discovered that we're using the word kupuna a little bit differently today, kind of broadly to describe like any almost like the word senior citizen. But traditionally, it was only used for people that you had a really specific relationship to, either a genealogical relationship or a social relationship to. And then together, Hakupuna is actually more than the sum of its parts, and it's actually the name of a specific ritual that you I don't want to say used to because I think some people still do this, although it's not as common. It's the name of a specific ritual that happens towards the end of a person's life when an elder would select someone to basically carry on their mana after they pass. And so that would take place by breathing either into the person's mouth or onto their head here. So, we all know the pico on our stomach, our belly button, but Kanaka actually believe that we have three pico and one of them is here. So sometimes they would breathe here as well. And that was to transfer that life's energy into the selected person. So we use this name and this ritual as a way to remind us of our mission, which is to improve the health and increase the life expectancy of our kupuna so that they're able to pass on that mana to the future generations of their family. You can see in our little logo there, that is actually Uncle Kikuni in the logo as well, sharing ha with a child. So today, I'm going to turn it over to Kaylin to talk about one of our projects, which is an interview project in partnership with Alulike, and we want to share some of our findings. Kaylin.
Yes, so the title of our project is looking at healthcare experiences of Native Hawaiian elders and their advice to providers. So like Shelley was saying, this was a project we did in collaboration with Alulike, which is the Title VI provider in our state. They have 14 sites across 5 islands, and we worked with their Kumukahi program specifically, which is for their elders. They're Native Hawaiian elders, and they provide meal services, they provide educational resources, they provide cultural activities, caregiver services, and then it's also just a space for the elders to socialize with one another and make new friends or, yeah, just spend time with each other. So that's who we worked with for this project. And so for the project details, so we had 2 main goals of this 5-year-long project. And the first one was to gather stories of the strength and resilience of Native Hawaiian kupuna. And the second one was to explore kupuna healthcare experiences, as well as identify strategies to improve their care. And like I said, this was in partnership with Alulike. So the kupuna that participated, they had to be 60 years old, and they also had to be identified as Native Hawaiian as well. And let's see the next slide here. Yeah, so for this project, it mainly took place during COVID, the height of COVID. So it was a really good time for the elders to be able to socialize and talk story, and just we got to know them very well. So it was a really good experience. So the logistics of the projects, we did 3 Zoom interviews with each kupuna, and they lasted anywhere from 45 minutes to 2.5 hours. The first interview, we just talked story with them, get to know their life, where they were from, where, they're more about their family members and things like that, just to establish rapport. And so they don't see us as strangers. And then our next interview, we looked more at life experiences with them. So we asked them, what were some challenges they faced during their life? How did they overcome these challenges? And then another part of interview 2 was to ask them what they learned from their kupuna and what they would like to pass on to the next generation. And then lastly, our third interview focused on healthcare experiences, both negative and positive, as well as that, what is your advice to providers? So that was kind of the logistics of the interview. After they partook in all 3 interviews and completed that, we gave them a makana. So as you can see, there's a picture on the right side of what they were gifted after they participated. So they received pa'akai, mamaki tea, dried bananas, and a personalized thank you card, as well as a life story written about them, based off the interviews and what the information they shared with us. And then also digital and hard copies of the video recordings and the transcripts written out of the recordings. And they were able to share this with their family and friends if they wanted to. So yeah, this is a 5-year long project, and we are now beginning year 4. But looking back at year 1, we completed 11 interviews. So we did 4 on Molokai, 4 on Kauai, 3 in Hilo. And after year 1, we really looked at interview 3, which was the healthcare findings. And we presented those findings at the annual Public Health Association conference. And then we also disseminated the findings in a manuscript in Frontiers in Public Health Journal. And then year 2, we completed 9 interviews. 2 were in Hilo, 3 were in Kona, and 4 were on Maui. And after that year, we mainly looked at interview 2, and we looked at the strength and resiliency findings, the challenges that the Kupuna overcame during their life, and those findings were presented at APHA as well. And then the last year of interviewing, we completed 10 interviews, so 1 on Maui and then 9 here on Oahu. And we looked at advice to providers after that year, and we also presented that at the Hawaii Pacific Gerontological Society conference back in September.
I'm gonna interject one quick thing here.
Go ahead.
So I didn't catch this before, but instead it says completed 11 interviews or 9, 10. It should really say Kupunabi, and it was 33 interviews because each person was interviewed 3 times.
3 times.
Yeah, so
Yeah.
I was like, oh, that number seems small, but yeah, no, it was 11 people, 3 interviews each. Yeah. Wow.
Exactly. And yeah, we're taking this year 4 and 5 to analyze the data and disseminate as well. Yeah, so looking at the people that participated, so these are the demographic breakdowns. So we had 25 women and we had 3 men participate. 2 were Mahu and transgender, male to female. And as you can see, there was more women that participated, and this was just reflective of the Alulike demographics because they have more women that participate. And then moving on, the average age was 74 years old. However, we had a very wide range from 60 years old to 88 years old being our oldest. 15 out of the 30 kupuna were living on Hawaiian homestead lands. 70% were attended college. They all listed that they had health insurance. And then on a survey that we gave them, we asked them to rate their access to healthcare, 1 being poor and 4 being excellent. So looking at primary care, the average rating was 3.41. Looking at specialty care, the average rating was 3.21. Mental health services was 2.91. And then the average self-rated overall health was 2.76. And yeah, so for these are our main themes that we looked at. So we had early life experiences with healthcare. So what was it like growing up? What did you do to maintain health and things like that, as well as their positive and negative healthcare experiences, their experiences with caregiving and long-term care, whether that be for them or previous family members. And then lastly, advice for providers, which is one of our main focuses of today. So we're going to go through and share some sub-themes that we have from each category here, and then also share some quotes. So, Shelley, did you have anything to add or?
Nope, you're doing
okay. Okay, sounds good. So yeah, first category here we have is early life experiences with healthcare. So one of the sub-themes we discovered was many participants did not see a Western provider growing up unless it was for immunizations or serious illness and injuries. So here's a quote is, when you got burns, it wasn't run to the hospital. My tutu man or grandfather would go outside, or my father would go outside, get a loy for the burns, put it on the burns. And I remember one time I was in church. My son had a really high fever and they went and got tea leaf. One of the kupunas got tea leaf and put it on him to bring the fever down. So it wasn't run to the hospital, run to the doctor. It was always the natural stuff.
The second sub-theme we found for the early life experiences with healthcare was that all of the participants told stories of that their family successfully maintained their health and treated illnesses and injuries with Hawaiian health practices. So, for example, la'au lapa'au, which is herbal medicine, pule, which is prayer, ho'oponopono, which is like a conflict resolution process, lomi lomi or massage, and aipono, which is kind of a preventative healthy eating. So here's a quote demonstrating that. I remember one time I got cut on my hand, and back then insurance, we didn't have insurance, I'm sure. And they fix it themselves. And the cut I would get from the sickle, I was cutting grass. It was like it needed suturing. But all my mom them did was put the hono hono because it gets sap, yeah, and it stopped the bleeding. So there's a lot of plant things as we grew up that my parents used, yeah. So it was learning. But like I said, they don't need it now because if they get hurt, first thing they go ER, they go to the doctor. But back then, we had to do it.
So for the next theme we have is positive healthcare experiences. And one thing we discovered was majority of the kupuna currently use both Western medicine and Hawaiian wellness practices. So one of the quotes was, you got to take Western medicine that you swallow and then it works inside out. And that's what they say. It needs to be healed from the inside out. That's why Hawaiians drink a lot of different kinds of tea and it works from the inside out.
On the flip side, we also wanted to hear about negative healthcare experiences. And one of the common reasons that a healthcare experience was not positive was because of poor communication from providers. And so here's a quote from one of the kupuna. Be understanding to us. Just give us a chance and let us say things. But sometimes they just cut us short. Let us finish our sentence, even if it takes long. Sometimes we get hard time taught. We share, but once you cut, waki us, all pau. We don't like say nothing. We pa'akawaha, which means we just shut our mouth.
And the next thing we looked at was caregiving and long-term care. Like I said, this could be for themselves or somebody they took care of in the past. So participants talked about providing care to a loved one, the importance of documenting their own care preferences, and the desire to age in place. One of the quotes was, hospice would come and help us and give us a chance to rest. I thought hospice nurses was one of a kind. I would have a hard time because they get so close to you. They treat the patient like that's their mom, their grandma.
One of the major themes that we focused on was about advice to providers. And so, we were trying to tell the kupuna, okay, if you're able to have somebody in front of you right now, what would you want them to know, and you're not gonna hurt us our feelings, just tell us, whatever you're thinking. So one of the first things that came up as a theme was they would really like providers to take the time to talk story and get to know them as people and as community members. So not strictly clinical topics. So here's some of the quotes. I would rather have a doctor who can see me eye to eye and we can talk. Oh, how are you? Or what can I do for you today? Or, pehea ko ohana, how's your family? That's how you relate and get closer. Another person said, it's not just about the medicine. It's not just about why am I sick. Gee, I stay with the doctor half an hour to an hour. We just wala'au and we kuka kuka. And that sometimes is good. It's healthy.
And then a second sub-theme that we had from the advice to providers was learn about and acknowledge Hawaiians' experiences with colonization, respectfully approach the traditional health practices of your patients. And this was after we asked them, what can doctors do to learn more about Hawaiian culture? And a few of the quotes here is, you learn and treat the whole person, not just a symptom, and you got to understand where the genesis of that symptom comes from and treat that instead of just giving a drug to numb. You got to treat the root of it, and they don't teach that much in medical schools. And then the second one is, I think I would like to see Hawaiian medicine along with regular American medicine. I think that would really help in introducing Hawaiian medicine because it works. It's just getting it and doing it and taking it because it works and I've seen it work.
Just a quick note on those first 2 points and how they relate to each other. We didn't hear a lot of examples, but we did hear a few examples where kupuna felt shamed or disrespected when they shared that they were, or discouraged when they shared that they were doing a traditional health practice. And like the one quote said, then we just pa'akawaha, which is essentially that they just won't tell you. And that's not ideal. It's better. And so the first point about building that rapport and getting to know them as people will help them feel comfortable to share those kinds of things. So that's a great segue into this next one, which is to communicate directly, clearly, and patiently. So the first quote here is, "If you're gonna tell me something, just tell me straight." I said, "Dot, just tell me the true facts." She was straightforward, and I like that. And that was a sentiment we heard from multiple people. Another one is, "What made the interaction positive is that the communication was clear on both sides. And if I didn't quite understand, they would show me pictures or diagrams, and they would tell me what they're going to do through the whole process, what's going to happen after I'm done, and then from there, the follow-up with more literature or whatever needs to be done."
And then lastly, we had a lot of kupuna share that they want providers to love what they do and show their passion in their work. So one of the first quotes here was, "Be patient, be respectful, have a sense of humor, don't show disdain, do your best, or else don't go into that kind of work unless you can be supportive and respectful of the patient. Don't go into it if you're just doing it for the money, because it's more than that." And the second quote we have here is, "Put your heart in it. Whatever you do it from your heart. And don't judge who they are, where they come from. This can be a homeless person. It can be a rich person. They're still a human being. The main thing for me is to really aloha, take care with your heart." And I think that wraps up the presentation part. And we're going to do questions now. Yeah.
All right. Well, thanks so much to both of you for that first part. Really some excellent, rich words coming from folks themselves. And I don't have any questions in the chat box right now. So what we might do first is just kind of check in with our panel to see if anyone wants to add their 2 cents. Just take a little bit of time to go through the panel and see if folks have any thoughts, anything to add from their particular perspectives and field. Yeah. So Sarah, why don't we start with you and sort of social work perspective?
I think the biggest takeaway for me, as I was hearing both Shelley and Kaylin speak, was the importance of communication. And it's even before you provide direct and clear communication, you were able to emphasize and affirm the importance of getting to know the person, getting to know your patient, because in doing so, you're developing a relationship. And it should be that way regardless of what culture, regardless of whatever culture you come from. I think we're trying to spend more time with all other disciplines, impressing upon them the importance of developing rapport and trust starts by getting to know the person. And I have had clients say, a patient say, Sarah, I wish they would just close the laptop. I go inside there, the first thing they do, I know they're going to tell me all the bad things about my blood sugar and my cholesterol. They don't even ask me, how are you doing today, Sarah? So that was an important takeaway and good advice for us as providers, is just even 3 minutes of just checking in with the person and how they're doing, or their caregiver, says a lot. So thank you both for emphasizing relationship is important.
Thank you, Sarah. Rita Bell, how about sort of from a geriatrician perspective? Rita Bell.
I was thrilled to hear that hospice was so well accepted with Native Hawaiians. So that we need to remember to refer to hospice more often, because sometimes we think our patients may not be accepting or they may be hesitant for hospice. But I'm very glad to find out from your research and study that hospice is widely accepted. Thank you.
All right, thank you, Rita Bell. How about Susie from a physical therapy perspective?
I think my takeaway was very similar to Sarah, that just the importance of communication, asking, like, getting to know the person, asking, how they're doing. I'm in a very fortunate situation as a geriatric physical therapist. We spend 45 minutes to an hour with our patients, and we can, we get to know them, we get to know their life stories. That's why I love what I do. And I've learned so much from, I know our Kupuna. So it's been I feel very honored that I really can get to know, my patients and their life stories.
Thank you, Susie. And Reese, how about from a pharmacy perspective?
I thought it was really interesting how a lot of the uh, Kupuna gave examples of traditional medicines that they used to use as a child, and you interviewed Kupuna from across the islands, and I'm sure every family had their own traditional medicines that they used, and yeah, it sounds like you could really write a whole book on the alternative medicine. Thank you.
Yeah, thanks, Reese. And so just my own couple 2 cents here from a psychology perspective. Yeah, I think the importance of that relationship stands out to me a lot, and in the words that we heard from participants in the study. And it's interesting because in psychology training from a Western perspective, there's often this very explicit line of disclosure of like, you have to sort of keep yourself out of it, of the work that you're doing, out as if you're not really like a complex human. You're like someone providing something to this person. So there's this really one-way thing. But training, I trained at Yola Lahui, which is a nonprofit working with Native Hawaiians, and very clearly in my training, we had to adjust our relationship to disclosure, and it was actually way more important to be able to share parts of your life so that the other person could trust you. And knowing the many decades of mistreatment and disparity experienced by Native Hawaiians by Western institutions, mistrust is actually understandable, very understandable. So us as providers actually going out of our way to try to foster trust by meeting the person where they are, caring of ourselves. Yeah, really, really important. So thank you both for sharing all this with us so far. Any questions from the folks joining us today? And if we don't have any now, you can keep putting that in the chat. And I think Shelley and Caitlin have some cases that you folks want to share with us.
Before we jump to the cases, I just wanted to respond to what Lucas was sharing about the self-disclosure and how that is a departure from, I think, a lot of our training. And that it did come up specifically with some of the kupuna, that it wasn't only about them feeling comfortable to share, but it was actually about the provider sharing that with them about, their family, their kids, where they grew up, something. And I think it really changes the power dynamic inside of an interaction. It's really uneven if it's like the patient is bearing their soul to you and you're just receiving that but not meeting them. So there's when we judiciously self-disclose, it can help bring a different balance to the interaction, and make people feel a little bit less like they're hanging out there all on their own. Yeah.
I think there's therapeutic value. I was just going to add to what you're saying too. There's really a lot of therapeutic value in that, because it gives permission then to that person, the client or the patient, to feel like, oh, okay, well, I didn't know Lucas probably knows my auntie and uncle. So, right, this always comes up, and he went to the same high school that so and so went to, and I think those connections really are helpful to create um, again, it really allows people to sort of tell more about what's going on with their health or mental health or anything else that's going on in their life. And it's continuous, right, Shelley? It's not something that just ends at that one interview. Or I mean, maybe Lucas, you have more to add to that.
Right. And so depending on your field and the type of contact you can have with clients is going to change how you approach the development of that relationship. But yeah, I think I disagree with everything folks are saying. And I guess, one thing that people sometimes struggle with is, okay, well then how do I know what kind of disclosure is useful and what kind is not? And I guess what I use as my guiding line is I'm willing to share a lot about myself, but I never want, I don't want the patient or client to start to feel like they have to take care of me, so that we can try to keep the focus of care on the person and have this be their space. But I bring myself as a full human as well into that relationship of working together, instead of, right, like the power dynamic can become, I'm telling you what to do because I'm the expert. Well, they're the expert on themselves.
Right. And we had to remember that too, like even as researchers, like I think what we're describing is people's relationship to authority. And so a lot of that comes from their educational experiences, also like healthcare experiences. And so, we also had to go through a process of building rapport with them and our boss, because it's a team effort to like go through the transcripts, and she's watching the recording, she's laughing, she says, "Man, Shelly, you're related to every person we interviewed," or gee, and I had to tell her, it's not just a matter of like, we're definitely not trying to make it the Shelly show. It's specifically time for interviewing them, but it's something that we have to practice, like learning to get good judgment around that, because it's an accountability. It's a different kind of accountability, right? So like if they know my family, they know I'm not going to be like acting up any kind, because they, there's other means of accountability. So that piece. But the other thing I realized was that for the kupuna to feel like we get them, like for them to understand that like this is not going to be pearls before swine, as they say. Like this person is going to be able to actually receive and value what I share. And so that to me is another like reason to make those kinds of personal connections. But sorry, Susie, I think I might have cut you off.
Oh no, I just had a question, and it might be too early to ask this question, but uh, did you find in your research and in your interviews that are the elderly folks, are they having a harder time like finding um home, like assisted living homes or care homes, or places for long-term placement? um are they having a hard time, due to financial constraints, or is it social issues? Anything you can tell me about that?
Yeah, it really varied by island. Like on Molokai specifically, there is no long-term care
Right.
facility. They have some long-term care beds at the hospital. But I would say generally there's a real strong sense that family should take care, which of course is like sometimes we get to a point where people need clinical support.
Mm-hmm.
And but for a lot, I think Kaylin can jump into, but for a lot of folks, the care was happening at home. Um, I didn't hear specific things like we wanted to be in a facility, but finances were a barrier. It was more like we're gonna do it at home if we could. Um, yeah.
But at the same time, more modern day, they're kind of also saying we don't want to put the burden on our children at the same time, even
Right.
though I took care of my parents. So that was just something else we found. But yeah, just echoing from Shelley, I think it just depends on which island we were on. Yeah.
And kind of personality too, yeah. Some of them were like, I told my kids, just put me in a home, you know, like I don't want to burden them. They have family that, and they're like really worried about that. A few of them planned ahead and got long-term care insurance and were really like intentional about that. And on the other end of the spectrum, some people are like, oh no, like this particular daughter or this particular like family member knows that like they are the one that will take care of me. Like we've already talked about it. Everybody knows, so whether it's planning ahead to get a professional
Mm-hmm.
care or to have a family caregiver, I would say most of them were already thinking about that,
That's good.
and communicating that, because I think a lot of folks have seen really challenging situations when there isn't conversation ahead of time. So I don't know, Kaylin, would you say that's accurate? We heard a lot of folks expressing that.
Well, thank you for that information.
Should we jump into the case study? Let's see what time. Okay,
Sure.
I'll pull it up.
All right. So I'm just gonna, you can just read along with me, or if you want to close your eyes and just listen, if that's a better way for you, just jump in here. Okay, so Dr. Kale is a primary care physician in Honolulu, and they have a diverse patient population, including many Native Hawaiian elders. He prides himself on providing culturally sensitive care while also managing the time constraints inherent in a busy medical practice. So Kalani is a 75-year-old Native Hawaiian man, and he visits Dr. Kali's clinic for the first time since his PCP of 30 years has retired. He's there just for a routine checkup and is accompanied by his family, including his wife, his son, and his granddaughter. He's proud of his strong ties to his culture and community, and he values the presence and support of his ohana on his healthcare journey. So Dr. Kale notices the large group in attendance with Kalani. Additionally, he recalls that Kupuna, like Kalani, often enjoy talking story and engaging in conversation as a way to build rapport. Dr. Kale appreciates the inclusion of family and the importance of talking story, but is also mindful of the limited time available for each patient encounter. So Dr. Kale needs to find a balance between respecting Kalani's cultural preferences for including his family in his care, while also managing professional boundaries like confidentiality and managing the time efficiently for the visit. He understands the value of getting to know his patients beyond their medical conditions, but worries about appearing rude or dismissive if he needs to cut the conversation short due to time constraints. So what are some things that Dr. Kale should keep in mind during Kalani's first visit with him? And what should he keep in mind for future visits together?
Hey folks, I'm Kupuna, one of the geriatric fellows, part of the UH geriatric program. This is a common theme in primary care where you have Kupuna who have had a PCP for 30 years and you're trying to balance like how Dr. Kalei is doing, being culturally sensitive, but also managing time constraints. So, definitely for a first time visit, you want to designate at least, half an hour to 45 minutes and providing expectations at the beginning, just so that everyone's on the same page is what I would do. But also allowing them to just talk story. We always can bring them back for a follow-up visit. But all needing to respect your other patient's time is always a struggle. But that first visit is very important as we all have our first impressions, and they've had a PCP for 30 years, so they're also judging us. So really taking that time to just get to know them as much as you can in that time period is what I would recommend.
Sarah, you have something to add?
Yes, I was just going to add, along with what Pono's saying, assuming I don't know if Dr. Kalei's in the same clinic that was shared by the Kalani's PCP of 30 years. If that were the case, there is already that's use that to your advantage, because at least Kalani knows, he's familiar with the staff in the clinic. He knows where his PCP was for 30 years. But you're absolutely right, Pono, is I think there's a way to be tactful and direct and just let people know that, it's so nice to meet you, Kalani. And, who is this? He's introducing his family members, but to let him know that I want to spend the next 30, 40, 45 minutes um, getting to know you as a person, but I also need to complete this physical exam. And I have some follow up. And I think you're right by letting him know up front what that time frame is, because as a social worker, I find that very helpful. If I don't set those limits for myself, and I'm sure the therapists, Lucas knows I've got people in the, waiting outside or paging me. And I think it goes back to what the two speakers were saying, is that we need to be clear, we need to be direct, tactful, and be patient. So right on, Dr. Pono.
Thank you, Kupuna and Sarah. And Marinelle has a comment or a thought, maybe not bring the whole family, ask if wife or son can attend, and have the family explain to the rest of the family. Marinelle, do you want to expand on that a little bit, or other folks have any comments about if we were going to do that, why and maybe how would we ask Kalani about his preferences for that?
Hi, this is Mary. Yeah, I understand like the whole family gotta come, but maybe like after the first visit, maybe or before the first visit ends, just say, hey, maybe we could just have one of your family member and you guys can explain it to the rest of them, just because of the explaining that, there is a time limit, even though we all wish there shouldn't be a time limit.
We're really trying to walk the line between these two seeming needs, which is honor the person, provide the time, create this environment, relationship, but also the constraints that we face. One thing that I often like to do after a first visit, I'm not a PCP, but similar in the sense of like asking Kalani, like, so how was it to talk to me today? I'm not Dr. Calais, but I might say, I'm a Howley psychologist man, like of a certain age, and we have certain similarities and differences. And was there anything that I said that showed that my understanding was really off, or anything I said that kind of bothered you? And oftentimes I'll get, no, it's fine, but at least the door gets open to my desire for some feedback and my knowledge that I'm a person here and I affect this interaction with who I am, who I bring through the door myself.
I think that humility is very important, Lucas, that you humbled yourself before each of your, I think just knowing who you are, I think you do that all the time to ask for feedback. But sometimes you might just be able to identify in the family who the spokesperson or persons are going to be. And what I do oftentimes is I'll sit and I'll actually write out during the first meeting or two, I'll write out like what happened at that meeting. And as I will give that written report to the family, because there's something called after visit summaries, but it still doesn't really clearly explain what happened in the meeting. And so it'll say what was the purpose of the meeting, what did the doctor say, what is the plan for the next visit, and what are the family going to do, what are they going to do before the next visit, and what would be the expectations of the doctor. So that's kind of been helpful, is to give a gift to the family, something in writing.
I have a comment. I just don't know how to raise my hand on the computer screen, but we will see our patients. They will they're in assisted living homes and care homes. Family isn't present, But they usually know that, when we're coming to do the evaluation. And we will get a lot of times, oh, can you please, I want to be there, or, my sisters want to be there. And we will just politely just say too, like, we'll just say, you know what, you know, we only have just a little bit of time, a certain amount of time. And I really want to get to know like your dad, and I want to see what he can do on his own or what she can do on his own. And I reassure them that I will always call. So, and I always call, like, we always have like one contact person, to talk to, like, not the, it can become very time consuming if there's like a lot of families who are like, wanting to talk to us. So it's like, we always establish that one person that we are going to talk to, and they are that person that is going to disperse the information to the family. And typically, if we are, if we have kindness and humility, and we're not trying to push them out, most of the time, 99% of the time, the family is like, oh, okay, well, I'll just wait until, after you see them, and I'll wait for your phone call.
Thanks, Susie. So there's ways of trying to express or balance these different kind of competing needs in ways that are acceptable to families in many cases. So, Renata added that she likes that the family members are involved, perhaps discuss with all present family members. It's important to allow respite to family members, and that not all family members need to be present for all visits, and divide up care responsibility. So even framing it in a way so that folks can actually benefit from sort of a dividing up responsibilities. Great. Well, any other questions or comments, or and Shelley and Kaylin, I want to leave. We have only a few minutes left. Anything, closing remarks, or things you want to add to what we've said so far?
The hour just flew by. I really appreciated the conversation we just had, because yes, everything that Kupuna said, and Sarah, Lucas, everything everybody added was exactly what we would have recommended, and more. In terms of how to handle a large family in the office, I would say, if possible, I would probably not ask them to not bring people. I would probably not I wouldn't want them to feel unwelcome unless it became a problem. And then some of the other techniques that folks are talking about, framing it as like respite for, we don't want to burn folks out. Not every, I know you have to take off work, we don't want everybody to have to come every time, because we got to think about the long haul, like that kind of framing, as opposed to like, please don't bring your whole gang. Or even like what Susie shared about, like, it's really important that we can assess what they can do on their own, kind of thing. But also, I really like the kind of signposting about the time that you have available that day, that can be really helpful. Clear, manage expectations around that. And then also what Lucas shared about just asking for feedback. And actually exactly what Sarah said too about, if you did know the previous PCP, to make that connection, to just mention, and just to kind of give a little bit more like relevance that we have shared social circles, or we have some folks in common and stuff, would really be helpful. But like Lucas said, asking for that feedback, not only, even if they have nothing to say, that they're gonna know, oh wow, this person is like, it's safe for me to express if I'm not feeling good about the way that this is going. And many kupuna kind of express to us that it's hard sometimes to just like ask a question on your own. So when we invite questions and just like give them that time and space, then that really helps. Kaylin, did you want to add anything?
No, I think you said it really well. Yeah, I think we hit a lot of the points here.
I think I know we're almost at time. Kaylin, do you want to bring
Yeah.
up our last slide? It just has our
Yes.
website information. There's lots of free resources there. We just recently completed a Hawaiian language glossary and collection of Olelo no Eau. about aging and elderhood that's available for free download. There's fact sheets about this interview project and some of the life expectancy and chronic disease disparities we talked about. And so, please find us there or email us if you want to talk story more about any of this.
Well, I want to thank you both for joining us today, Shelley and Kaylin. And this is, really rich presentation and just scratching the surface. I feel like, there's so much more that we could go into, and we have this hour, it flies by, and I really, I want to appreciate you for beginning this conversation with us and pointing us in the direction of further learning, which is an endless, lifelong journey, right? We're never done learning. So mahalo to everyone who came today, and we have links for CME evaluations in the chat, so please do that. And we just wrap up here in a few minutes, but have a few minutes left if anyone has anything else they want to add.
I just wanted to add a little, as a native wine provider, it's great when you interact with native wine patients to provide a sense of place is important, of knowing kind of where they're from and where you're from really helps to make that social connections. Because as we all know, Hawaii is very small and everyone knows everyone. And I think that's a great way to break, those initial barriers when you have these first time visits. So I think it goes back to what Lucas was saying about disclosing and what Shelley was saying, but, just keeping it very light of like, where you're from, what high school did you go to, that really kind of paints a bigger picture instead of just we're here in the clinic, I'm the doctor, you're the patient. So I just wanted to re-emphasize that and appreciate that you folks have shared that in this presentation.
I feel like people always kind of stereotype the like where you went to high school question in Hawaii, and it's kind of like folksy and funny, but I think it actually is such a nice way to really build connection, and that's like the point of Talk Story, is to make connection, and that's what makes it feel different than like an interview or an interrogation, right? Is that you're like mutually sharing and you're trying to find like a common ground for each other.
Yeah, we definitely had Kupuna say, "Oh, that doctor went to the same high school as me. I trust him already," and just things like that. So yeah, those little even those little connections are great. Yeah, thank you.
Yeah, because in old time, the kahuna, they weren't as how Western providers are perceived. They were there to provide guidance and show patients kind of the way to health and not kind of the institutionalization how it is now. So really bringing back that relationship kind of helps not only Native Hawaiians, but other indigenous peoples um, as they have experienced kind of this shift in their relationships. So that was really helpful to hear the manao from the kupuna.
Mahalo, everyone. And we're just about at the hour mark. So hope everyone has a wonderful rest of your day, and hope to see you again at future Geri Echoes. So
Mahalo,
ahui
Kelly.
ho.
Mahalo,